Good afternoon, everyone, and welcome to Wonderful Wednesdays. Thank you for joining. This is part 2 of missed cardiac diagnoses, and we're going to take a look at 2 different situations with patients. So in our prior conversation, we talked about a couple of different patients, and now we're going to talk about a 68-year-old female who has a prior history of hypertension, but no known heart disease, no known issues. She's admitted to our hospital on June 7th, 2021. She actually was in our emergency department viewing and identifying her son who had been killed in an automobile accident. And as she was viewing the body, she had a witnessed VF arrest. And of course, she received excellent bystander CPR in the emergency department, and she had return of spontaneous circulation after about 20 minutes and 6 defibrillations. Her post-rhythm, and we're going to look at her post-rhythm EKG by the diagnosis of the providers, her post-rhythm EKG shows left bundle branch block at a rate of 60, and a bedside transthoracic echocardiogram showed severe hypokinesis of the mid to the base of the heart. So just thinking about the base, that's where the point of maximal impulse is, and all the way up to the mid-heart, there was significant hypokinesis with much worse akinesis, so no movement at all, along the lateral wall. Now, of course, the concern was that she had an acute STEMI, and in the setting of that VF arrest and a new conduction delay, assumably left bundle branch block, as well as the decreased left ventricular function and wall abnormalities, she's taken immediately to the cath lab after she has return of spontaneous circulation for an emergent left heart catheterization. And her primary diagnosis is VF arrest and left bundle branch block. So off she goes. She actually gets pads for cooling for TTM, and the husband has consented for her cardiac cath. Now, most important to note is that her left heart cath reveals that she has completely normal coronary arteries, and she's admitted now into the intensive care unit to continue with her targeted temperature management. For us, with a typically with an out-of-hospital cardiac arrest, we'll do TTM to 33 degrees, but because she was in hospital with a witness and with immediate bystander CPR, we actually put her to 37 degrees. Okay, so this is her first EKG right after the cardiac arrest and return of spontaneous circulation while she was in the trauma viewing room viewing her son's body. So one can see when you look along here that all current is going away from the right, V1, V2, and V3 are right-sided leads, and current goes away. That's what that major downward is. And it's taking an extraordinary amount of time. Now we comprise that, or we look at that as well with the left-sided leads, and you can see current is going towards the left and taking a lot of time. So downwards in V1, V2, V3, upwards in V4, V5, V6, and there's a time delay. So very naturally, one would look at this and think, this looks like a left bundle branch block. Okay, well, that's fantastic, except for one thing. When you do a 12-lead EKG, you should always get at least 1, if not 2 leads in a rhythm strip. So if we look at this, you see that this is about 3 seconds in time, 3, 6, 9, and 12. But down here on the rhythm strip, you get 12 seconds in the same lead. And when you're looking at this rhythm strip, it would be very hard to actually say that every QRS has a P wave preceding it. So you can see here you have a P, here not so certain. There might be one somewhere buried in there. There's a little blip here, but it doesn't look the same as that. Here's another one. It looks like a conducted beat. This is a little bit different, maybe none here, one here. I would have liked to see a second rhythm strip. Typically, if you're looking for P waves, it would be lead 2 and V1, which will give you the best visualization of P waves. Because at this point, I'm uncertain. At this point, looking at this EKG, I actually think it looks like a left bundle branch block. It absolutely does. But I'm not certain that it's not idioventricular rhythm, which we're going to treat differently than we would treat a left bundle branch block or an acute STEMI. But in either case, she gets another EKG at 11:51. Now, this one seems a little more clear because now what I did not see before were P waves before every QRS, and I am now seeing P waves before every QRS. But you can see things look a little different. Okay, so V1, V2, V3, the current is going away. It's taking a lot of time. V4, V5, and V6. Current is coming towards the positive electrode on the left side, V4, V5, V6, and it's taking a lot of time. But if we compare that here, there is some significant difference. Now, maybe it's lead placement, or maybe she actually has a left bundle branch block, but she also may have had some heart block that occurred immediately following her cardiac arrest. In either case, end result will be that you'll always have to consider, does this patient need a protective pacemaker? And then we take a look at her ABGs. So we're going to start with her ABGs here on 6-7 at 23:22. And you can see she's very well oxygenated. She does not really have respiratory acidosis, but she does have metabolic acidosis. Okay, that's really important. And then when we look down here, so this is her arterial blood gas, and down here is a central venous blood gas. And I've called this to your attention for two reasons. The main reason is that I want you to see the similarity of the pH, 7.29 in the arterial bed, 7.24 in the venous, and the base deficit, -4.1 in the venous and -4.2 in the arterial. Now, the reason I want you to note this is because a lot of times you can't immediately get an arterial stick. You may not have an arterial line, but you can always look at the venous sample to at least tell you about the presence of metabolic acidosis, which indeed she has. And she gets quite a bit of nice resuscitation over time. She goes off to the cath lab. She gets other types of resuscitation, volume, and some other things. And you can see that she has relatively quick return to a basic normal, both on the arterial side and the venous side. So really important. And as we move forward, we see very well oxygenated here. She's intubated. All of this is intubated, and this is post-intubation, post-extubation. So she had a little bit of hypoxemia post-extubation. Just when you pull a tube, it's a little harder to get the oxygen to the area that you need it to. But this did not cause any deterioration for her. And then we just take a quick look at her chemistry. And mostly what I want to focus on here in her chemistry, because most of her chemistry is relatively normal, except that she has some abnormal calcium, abnormal albumin levels. But mostly what I want you to focus on as we look at her is her total CK, which was a little bit elevated. And then I want you to look at her troponin level. So she starts at 0.03 and then goes up to 1.5, 1.7, 1.6, etc. And you can see that her beta natriuretic peptide hormone is quite elevated because she, of course, is in heart failure post her cardiac arrest. Now, what I want to introduce you to is something that you would always want to consider. Remember, I told you that her left heart catheterization showed clean coronary arteries. She had no occlusion. Now, sometimes individuals will have a clot in the coronary artery that dissolves and they reperfuse. By the time you do a cardiac cath, you don't really see anything. That's relatively unusual. But what she actually had is Takotsubo cardiomyopathy. That's more commonly known as broken heart syndrome. It is named for the Japanese octopus trap, which basically says that during your systole, what you see is that the apical portion of the ventricle contracts, but the base is hypo or akinetic, exactly what was described by her echocardiogram. Now, we call it frequently broken heart syndrome, and that's how people often will refer to it. A lot of times people have trouble saying Takotsubo, So they talk about it as broken heart syndrome. And the heart isn't actually broken, of course, and it really is related to a specific causative factor. And typically, not always, this kind of dysfunction can be resolved over time. So this is all really good news. Remember, most commonly, it will be seen in people who have clean coronary arteries. So this is the visualization of her heart on X-ray. And you can see this is an X-ray that's taken, this X-ray was taken during systole. There were multiple shots, and that okay, please remember to mute yourself when you join. Thank you so much. But you can see that narrowing more at the apical region of the heart and the ballooning at the base, which is very common when we talk about Takotsubo. Now, really, really important to appreciate that it presents very much like acute coronary syndrome, but it is not an actual acute myocardial infarction. It actually is from excessive release of catecholamines, and in particular, in severe stress response. So the pathology of Takotsubo, and that makes it really, really important. In this case, we knew exactly what happened, that she was viewing her dead son's body. He was in a motor vehicle collision. It was completely unexpected. She had a very, very significant physiologic stress response. Typically, catecholamines are 30 to 40 times normal when individuals have this type of syndrome. Now, that may also cause some vasospasming of the coronary arteries, but in the end, although it looks like, sounds like, smells like acute coronary syndrome, it is not typically a coronary event. When you're first evaluating folks, though, it does look like ACS, right? Because oftentimes, as a predictor, there may be some chest discomfort, there may be shortness of breath, both of which the patient actually experienced. I think the perspective was she was with a social worker, and the social worker probably thought it was a panic attack, and everybody would think that. Nobody else, I mean, she didn't have a history. You wouldn't think anything except this is a panic attack. She's viewing her dead son's body. But she will have elevated cardiac biomarkers, as we saw. There will be EKG changes, and most particularly, those EKG changes are about repolarization and depolarization time. So prolonged QRS, prolonged QT syndrome, sometimes a prolonged PR. And again, remembering that often there is a stressful cardiac triggering event. You do actually need to take these patients to cath lab because you cannot make a definitive diagnosis otherwise. A lot of times the EKG will not show you that profound octopus bottle shape, and you can't really make a diagnosis from the X-ray. You can't really look at the X-ray and say that that's the final say. So you really do have to go to the cath lab, which of course she did. So again, just as a reminder, what you're looking at here is during systole, the base of the heart is profoundly contracting. The apex is really wide. The base of the heart is what gives that contraction here. The apex of the heart, and I think I turned those words around a minute ago, I'm so sorry. So the apex of the heart is ballooned. Now, during diastole, what you just see is a heart that just looks like it's in heart failure or cardiomyopathy, and you can see that down here. It's really during systole that you're able to see this difference. So remember, the cardiac enzymes rise. Patient may have ST segment changes. They have a prolonged QT. The T wave may be flat or inverted, and there may be prolongation in electrical activation. So you can look like you have significant bundle branch block. And of course, you have symptoms that are similar to acute heart failure. So again, that classic clinical presentation is that there is no culprit coronary disease, which then means there is no coronary intervention required, most particularly defined by your echocardiogram, by looking at that whole perspective that the base of the heart, that's the part of the heart that is closest to the aorta, the base of the heart maintains its normal contraction, that it's the apices of the heart that does not contract effectively. And oftentimes this will present with cardiac arrest, It will present with myocardial stunning, which means, or what we call myocardial hibernation, just some abnormality that can persist for days to weeks. For some patients, it will persist for their lifetime. It also actually is an indicator that this may occur again. And most commonly seen in Caucasian women and most commonly seen in post-menopause time. So Caucasians, post-menopause, very common. So basic definition, you start with your EKG, but that doesn't define this. You do some blood tests to look at troponin spill, to look at heart failure indicators, and BNP still doesn't define it. You do an angiogram and you discover clean coronary arteries, and with fluoro, you may be able to evaluate this balloon shape as the heart is contracting. But the best thing, of course, will be an echocardiogram and a cardiac MRI. Now, we'll have some good indications on chest X-ray, and if you have suspicion that this is occurring, you do a series of X-rays so that you can capture the heart in both systole and in diastole. So really important to appreciate that this disorder has been labeled for over 20 years, but it still is missed very frequently. There's a very gray area about it. It's great if patients are presenting with this really significant, profound octopus trap picture, the Takotsubo, that's the name of the octopus trap. Very unusual. Usually all disorders are named for the doctors who discover them, but this is named for the appearance of the heart. But some patients will not have such an extraordinary change. Now, very severe cases will occur. They'll present with cardiogenic shock, basically class 4 heart failure, cardiac index less than 2.3, and evidence of venostasis of volume in the pulmonary bed. That would be the wedge pressure, the PAD, or acute profound pulmonary edema identified by the chest X-ray. And oftentimes, this is prodromal. This will occur again. And it's really important for us to appreciate that anybody who says, I have Takotsubo, you have to be hyper vigilant, hyper alert when you're evaluating them, because this can occur again. Okay, well, let me tell you, her story was pretty darn great because she recovered neurologically. She was very purposeful, alert, oriented, aware, and extremely sad. She had a cardiac MRI on 6/12. She was on the telemetry floor and sent for her cardiac MRI, and her LV, in terms of the diameter and the muscle, were somewhat altered. She had some mild left ventricular dysfunction. Her EF was 46%, normally 50 to 75. So just a mild reduction in her ejection fraction, but she actually had some global hypokinesis, and it was really much more related to the apices of the heart. Septal bounce means that the septum doesn't move the way it's supposed to. If you're aware of that, during filling of the heart, both right and left ventricle, the septal wall goes over into the left heart. And then when the left ventricle starts to eject, the septal wall should shift over to the right and then come back to the left and go back to the right. And her septal wall was just moving back and forth out of sync with the process that was occurring. But she didn't have any valve dysfunction. Her RV looked great. She didn't have anything that indicated myocardial fibrosis or scar tissue, no concern for myocarditis or other forms of cardiomyopathy, but she needed to be protected. And the way you protect these patients is by AICD. So they place an AICD. She's discharged home actually on 6/12. She comes back on 6/15. She gets her AICD and she's discharged home from the EP lab. So this is CVICU day 2. This is with her permission, and I've tried to make sure there's no identifiers here. And then on day 4. So quite extraordinary, really important, because in Takotsubo, when we recognize it early, And what we have to do is block the catecholamines. So you've got to go on beta block therapy because they have this huge surge of catecholamines that are putting the myocardium under stress, can actually cause vasospastic activity. And what we have to do is block that. And that's why it's so important to have an appropriate diagnosis in this situation. So day 2 and day 4, we actually took TTM off because she woke up. She was hyper alert. She was purposeful. She was aware. She was communicating, and she was extubated and taken off TTM by day 2. So basically she rebounded really quickly and resolved really quickly. That doesn't always happen like that. All right, so for our second patient, we're going to talk about some misdiagnosis and heart failure. And it's really important to remember that heart failure is frequently poorly evaluated. So yesterday I did a talk on vascular tone and vasopressors, and I presented a patient that was currently in our CVICU, who in January of this year, 46 years old, in January of this year, diagnosed with a left heart ejection fraction of around 20%. And he had never had symptoms before. He did not have known heart failure. My assumption, and this is, I think, what everybody believes, we don't know for certain. He had clean coronaries, so he did not have an MI. My assumption is that he had viral myocarditis. And particularly when we think about post-COVID, when we think about vaccination, we think about younger people, although that typically is much younger, usually teenagers, you always have to have some question about viral myocarditis. And viral myocarditis is really hard to diagnose. It's a diagnosis of basically of exclusion because we can't find any other factors. But in any case, the patient has heart failure with a reduced ejection fraction. So that would be HFrEF, reduced ejection fraction. If it's HFpEF, that's preserved ejection fraction. If it's HFrEF, that's reduced ejection fraction. So at some point, of course, he had something that was occurring that brought him either to the cardiac clinic at Grady or to his primary physician. He had some kind of symptom. Typically, the symptoms that people present with when they have heart failure that's not been diagnosed is that they have weight gain. And one of the most important ones is weight gain and inability to put your feet into shoes that fit you before. That's one of the best diagnostic tools. And of course, there's more scientific diagnoses, which is increasing shortness of breath, needing to sit up or sleep with pillows. You can't lay flat. You have increased urination at night. A lot of scientific principles that give us an idea that we have a patient who may be evolving heart failure. So he goes to to the cardiac clinic or to his GP or his family doctor, and there's a suspicion of heart failure, and he gets referred for an echocardiogram. So he gets an echocardiogram. He has a 20% EF. He seems very, at least by description, because I did not interview him, but by description, he seems quite knowledgeable about his disease. He knows that when his feet are really swollen or when he's really short of breath, he should diurese more. He also knows that when he diureses, he should be replacing his potassium, but he isn't necessarily understanding the effect of hypokalemia with excessive diuresis. So it would have been like last week, on some date last week, that he is admitted in cardiac arrest, a VF cardiac arrest, and the belief is that's secondary to hypokalemia. Now, the primary problem for this patient is he has reduced ejection fraction. He has end-stage heart failure that actually exacerbated from January to Sunday, where he actually went significantly downhill and decompensated. Wasn't really on any vasopressors, was on some minor inotropic support, wasn't intubated, was mobilizing around the intensive care unit. And of course, the consideration for a patient like this, who is young, who is relatively aware of his disease state and relatively compliant with medication. I don't like that word, but let me just say that is in control of his medications and is taking them as recommended appropriately or relatively so. This is going to be a patient that we're going to consider for transplant. He's young, previously healthy. He has significant reduction in cardiac contractility, and he really can't maintain himself. So he gets diagnosed for heart failure. He has a hypokalemic cardiac arrest. He's doing really, really well in the CVICU, and then he has some rapid and aggressive deterioration. So that's one patient. That's not even the patient we're going to talk about, but I was just thinking about this patient and how we evaluated him. So when you have severe symptoms, that's what brings you to the emergency department, the A&E, admission and emergency, or you see your GP or your family doctor, who then says, oh, it might be something else, and I'm going to kind of treat you for something other than that, but your symptoms get worse, and now you go back to your doctor, who then says, okay, we need a cardiologist. Or path B, immediately making a diagnosis of a cardiac event. Okay, now this is very, very, very important to us, because traditionally you're a 46-year-old man, you don't have any medical history, you don't have prior problems, you go to the clinic or you go to your primary care doctor. Typically, the first thing that's suspected is not heart failure. Now, if we're paying attention to the symptoms, and again, some simple things that we can talk about, and then we're looking at a profile. We're going to look at your BNP. We're going to look at some other issues that can tell us that you have heart failure. You're hyponatremic, you have a decreased serum osm, you have a high BNP. Remember, what happens with heart failure is one of the first things is you have reduction of blood flow through the kidney. So now you're retaining water because you're not having appropriate blood flow through the kidney. And whatever blood flow goes through the kidney, you're going to reabsorb salt. You're going to reabsorb water, because the kidney's perspective is you don't have blood volume. Kidney doesn't actually have a communication directly with the heart, and the heart's saying to the kidney, I've got heart failure. Don't reabsorb salt and water. You need to waste it. The kidney is reabsorbing salt and water. And so our patient gains all that water weight, and that water weight actually is relatively static in the ventricles, right ventricle and left ventricle. And it might be for him, left ventricle first and right ventricle second, or right ventricle first and left ventricle second. Don't really know. And ultimately, it doesn't really matter when we're talking about overtime management. It matters when we're talking about critical care management, but overtime with heart failure, it doesn't really matter. If you have biventricular failure, so both right and left ventricles are in failure, they're very dilated, they have a lot of volume in them, and that volume load in the ventricle backs up into the atria and up into the venous circulation. So pulmonary veins for left heart, systemic veins for right heart. Okay, so remember, it can be hard to make a correct diagnosis. A place where it's really difficult to make correct diagnosis, and where diagnosis is missed all the time, probably 70% of the time, are in postpartum women, because they're tired and they're exhausted and they can't really walk up and down the stairs, and they're kind of short of breath, and they get a little pat on the head. It's okay. This is just your hormones. Things will get better. Now, in the world today, we're doing a lot better at identifying this with women, but it is really important to appreciate that path A and path C are the more common paths, rather than path B, which is a correct diagnosis. That's going to be true for younger patients. That's going to be true for women. It's going to be true for especially hormonally changing women, so both menopause and postpartum, that looking at the hormonal influence on cardiac function and cardiac failure oftentimes can lead us to missing diagnosis. So that's a really important concept for us to appreciate. Heart failure is not a diagnosis made from an EKG. So you come into the emergency department, you get an EKG, you get labs, you get a troponin, you get a BNP, you get a chemistry profile, all of which is really good. But what we want to remind ourselves is that we have some very excellent clinical signs. Okay, so left heart failure only. So that would be early. Eventually, if your left heart fails, you're going to have some right heart failure. But early left heart failure, you're going to have respiratory wheezing. The apex of the heart is going to be displaced. So the apex of the heart sits at what we call, I'm acting like you can see, like this, the point of maximal impulse, which is at the fifth intercostal space, mid-clavicular line. When I put my hand there, I should feel the strongest pulse of the heart, as long as I can feel that. If you're obese, I might not be able to palpate it. But with left heart failure, because you have LV dilation, that point of maximal impulse is going to shift over towards the left side. So it's going to be more laterally displaced. And so the apex of the heart is displaced. The point of maximal impulse is displaced. You have lung crackles, you have respiratory wheeze. You also most likely will have mitral regurgitation. So that's your left-sided heart murmur. 15 people listen to a heart, 15 different interpretations. You have to be really, really excellent to isolate where this abnormality is, and it really depends on where you're listening. You have to listen at the pulmonic site for this, not the aortic site, and at the mitral site, which is fourth intercostal space, left side of the sternum, to really evaluate effectively. So it's pretty difficult to do a generalized clinical evaluation. But if you see things that are suggestive of left heart failure, it doesn't matter where you work. You're in cardiology, you're in medical ICU, you're in the emergency department, you're in the cath lab. If you see these suggestions of left heart failure, and that's new onset lung crackles and respiratory wheezes, those are going to be the first things, and you get an x-ray and the lungs look wet, you're always going to consider that may be a sign of left heart failure. For right heart failure, and that would be right heart failure or right heart failure secondary to left heart failure. So really, really important. Right heart failure in isolation, right heart failure secondary to left heart failure. That's backward failure from left heart through the pulmonary vasculature, and now the right side is overloaded. That's when you see patients have bilateral, generally equal bilateral pitting edema. So on both legs, not one leg. One leg may be a little worse than the other, but it will be both legs, unlike DVT, which tends to be a singular extremity. Also, very important, especially if the patient is having to sit a lot more frequently or commonly, you may have sacral edema. Something else that's really, really important is on palpation of the liver or compression of the liver, what you'll see is the neck veins will distend. That's called the positive hepatojugular reflex. But overall, their jugular veins are very distended. And you of course know that when you lay patients flat, you see the neck veins collapse, the neck veins engorge. And as you elevate them with the bed, not by themselves, as they elevate with the bed, you should see neck veins collapse at around 35 degrees elevation. So patients who have right heart failure are not going to collapse their neck veins. Typically, they don't even collapse them at 45 degrees. So that's like straight up. So that's one of the ways we can evaluate that patient. And because the right ventricle is now dilated, the leaflets of the tricuspid valve are pulled apart, and they're going to have a regurgitating murmur in the tricuspid area. And then when both ventricles are dysfunctional, you're going to see suggestion of the left heart, suggestion of the right heart, and failure of blood flow. So very cool peripheries, peripheral cyanosis, typically not central cyanosis, but peripheral cyanosis, delayed capillary refill, which is a great sign. All of a sudden has had a huge resurgence in evaluating patients. And of course, orthopnea, meaning I really can't lay flat. I have to sit up. I used to lie down and go to sleep in my bed, but now I sleep in a recliner. Or they say, I need 4 pillows at night. That's called PND, paroxysmal nocturnal dyspnea, which typically means that when you fall asleep, you get really short of breath. They use pillows. Eventually, they have to move into a chaise lounge because they can't lay down any longer. So these are really important. So pulmonary venous volume overload in isolation, LVH. Systemic venous volume overload in isolation, RVH. Pulmonary and systemic together, shared findings. You now have biventricular dysfunction. Okay, so now let's take a look at another patient. This is not the patient I was talking about. It's in the CVICU. This was a patient from about, a couple months ago, 2 months ago, 3 months ago. 52-year-old man with history of congestive failure. We already know he has CHF. His EF is 15%, and he comes into the emergency room because he's hypotensive, he's lightheaded, he's nauseated. He's had these symptoms for a couple of days. He went to the clinic to get followed up, and they found that his blood pressure was 80/50. He's dizzy. He's brought to the ED for further evaluation. Now, just this right here tells me that the likelihood is this is exacerbated or class 4 heart failure or cardiogenic shock. Says he doesn't have any chest pain, but he's been nauseated. He has shortness of breath. And whenever he lays down, he has palpitations, because remember, when you lay down, more blood gets returned to the heart is beating faster. And so this is a reason that we ask people about, do they notice that the heart beats faster when they lay down? Or sometimes they just tell you that they feel that. So he says he hasn't really been ill. He hasn't had fever, chills, congestion, no abdominal pain, no diarrhea, no constipation. He says he doesn't use drugs, he doesn't drink, and he was healthy. All right, he's 52. He was healthy prior to his congestive heart failure diagnosis. Now, he has already had an echo, and it's been ongoing for a short period of time, not for 5 years, but for about 1.5 years. But in the ED, he has tachycardia. Okay, now we always expect to see tachycardia with hypotension. But I want to actually remind you that patients who have heart failure actually become beta, from a contractile perspective, they become beta resistant. They actually have heart failure induced catecholamine resistance because they're always bombarding their heart with stimulation. So the fact that they have tachycardia tells you that they have very significant sympathetic stimulation. That's why the heart rate is up, and you should always, always, always investigate that. Okay, now it seems really intact in terms of his level of consciousness, and they do a point of care ultrasound, and they see, of course, that his EF is severely reduced. Well, we already know from a TTE, a transthoracic echocardiogram, that he has an EF of 15%. So the POCUS doesn't give us a quantifier. It just validates that he's got severely reduced ejection fraction. So here is his, his initial pressure, remember, in the clinic was 80/40, but now it's 96/78, and his heart rate's 103. So not profoundly elevated, doesn't have a temperature. His respiratory rate, however, is 28. Now, tachycardia and tachypnea, for me, are always a sign of impending doom. Always, always, always. I don't walk away from a room without investigating why my patient's got persistent tachycardia and tachypnea, because I'm going to see both of those as compensatory for low flow or high oxygen demand states. I think everybody was looking at that. They're evaluating his neurologic status. They're really looking at what else might be occurring. He does not really have abnormality in the eyes, and oftentimes we might have some actual scleral edema and also some jaundice in the eye beds as well, because we have hepatomegaly. So things look pretty good. From the physician's perspective, things look pretty good. And here's the list of the patient's problems. Okay, so again, the thing we're really concerned about here is his reduced ejection fraction. Here's something else we're going to be concerned about, that he has type 2 DM. He doesn't use insulin. But in this case, when you've got heart failure and you have persistent tachycardia and tachypnea, you have high level of sympathetic stimulation, and you typically are going to have some high level neurotransmitter release from the adrenal glands. So that means your circulating norepinephrine and epinephrine may be a little bit higher than they are normally, and that can create some insulin resistance. So when I know I've got a person with heart failure and I see that they have tachycardia and tachypnea, I'm going to be very concerned about their blood glucose. And you might be in a place where you have to have an order to measure blood glucose, but if you're not, you should just go ahead and measure the blood glucose and be sure that you're evaluating that, because hyperglycemia puts an extraordinary burden on the myocardium, and we don't want that to be exacerbated. Okay, so now we look at his labs. Okay, so here's his BNP. Always important to remember, beta natriuretic peptide hormone is a hormone that is released from the wall of the endothelium of both the right and left atria. And the atria releases this hormone in order to promote salt and water wasting, because the atrial wall is stretched and the ventricular wall is stretched. So whenever you see this greater than 200, that is always a significant indicator of heart failure. All right, so remember what else I said. Take a look at your patient's sodium. You take a look at their sodium, and you're going to expect with somebody who has exacerbated heart failure that sodium is going to be low. And then you go down here to the osm, and the osm is just 1 point above the low normal. So you've got some diluted plasma and you have a low sodium. I probably would have expected his osm to be a little bit lower, but we're okay. His glucose looks fine. His BUN is elevated. His creatinine is elevated. Okay, now lots of times we're going to use BUN as an indicator of volume status. So if you were only using it as an indicator of volume status, you would have expected it to be a little bit lower. But he also has acute kidney injury, actually has acute kidney failure, and his creatinine is 2.2. So this is telling you he doesn't really have good renal blood flow, which means he's not wasting salt, he's not wasting water, and his filtration rate, and that's just the filtering of the creatinine over a 24-hour period of time, is extraordinarily low. So he's got quite a few problems, and not the least of which, my friends, is also his potassium. Okay, because his potassium is very low. Now, that's going to be helpful to me kind of in some decision making, that what I want to do is I want him to waste water, and I want him to waste, you have to waste salt to waste water. But what we're going to try to do is get him to waste salt and water in conjunction with each other, and to lose more water than he loses salt. So his sodium will come up and his osm will come up. But I also have to assure that he doesn't waste any more potassium. As we waste sodium in the tubule of the kidney, so goes potassium. So even though we might use metolazone, we might use Lasix for this patient, what we're also going to do is we're going to assure that we're using a potassium sparing diuretic as well. And that would be spirolactone or aldactone. And just to note, this patient has a lot of similarity to the patient that I just talked about a little earlier with who was in the CVICU as of Monday. He transferred for ECMO, but he was somebody who had hypokalemia and hyponatremia, and they were diuresing him, but they weren't really doing potassium protection. So always be looking at that. This is really, this correlation here and this low osm all tells us that our patient is profoundly dilute, that he is diluting his sodium, that he's also primarily wasted potassium. And so we have to actually give him a potassium sparing diuretic along with potassium replacement. Now, he's not making any urine, or at this point, he may or may not be making any urine. If he is, it's very, very low because his GFR is 35. So we always want that to be 90. Yours and mine is probably 120 or 125. Okay, so we think about all those labs and what they're telling us and how this all points to a profound exacerbation of his heart failure. So sometimes it's just kind of like, oh yeah, well, we know he's got heart failure. He has an EF of 15%. No, this is profoundly exacerbated. And because of his initial presentation, I would probably have classified him as cardiogenic shock. So now we just take a quick look at his EKG. There's not much for us to know from his EKG, except it may give you an idea about the state of the muscle wall, whether the muscle is hypertrophied or not. But the EKG is not definitive in heart failure. It's also not definitive in hypertrophy. What has to be performed is an echocardiogram. A POCUS is nice. You can apply ultrasound. You can evaluate kind of generally what's occurring. Typically, you can't see the right heart, and it does not quantify your disorder, but it's a great tool to just give us a quick look. Now, he does have some significant abnormalities, but they don't point to whether this is heart failure or hypertrophy. We do have some conduction deficit. We've got some other problems with this patient. And of course, he's having aberrantly conducted PACs. Okay, that's not a PVC because look at the P wave before. This is a PAC and it's aberrantly conducted. Okay, so by my evaluation of his EKG, I believe that he's got a little bit, not much, incomplete left axis deviation. And I think his left axis deviation is not really evaluated here in the left-sided leads, or this lead 1, or AVL, which are left-sided leads. What I think his axis deviation is caused by is loss of half of his left bundle. Now that's more complicated than we actually have time for or you have desire to do. But it is really important to just remember when you look at an EKG, you expect upright in 1 and an upright in F. And here you have an upright in 1, but a primarily downward in F. Okay, that means current is going towards the left, but away from the foot, and that would be considered a left axis deviation. I believe this patient has what's known as a left anterior fascicular block. He looks like he may have had an anterior MI because he does not have much R wave that progresses through those leads. And he has some other abnormalities by EKG. We can't diagnose heart failure. There is no ST segment elevation, so he's not having an acute process. He has some things that muddy up the water, and they require a cardiologist to interpret. So you wouldn't actually say, oh, I've got to get this patient to the cath lab. There's nothing on here that indicates that he is having an acute myocardial injury or acute coronary syndrome. Nothing on his EKG that indicates it. Now, the nursing note says, patient asked to pee multiple times. What she means is she asked the patient if he could urinate, but he says he doesn't have to. So she's placed the urinal at the bedside. She's waiting for the patient to pee. She likes that word pee. Patient has to pee multiple times. Patient says he doesn't have to pee. He doesn't have any pee. Urinal at the bedside waiting for patient to pee. So I just like to call attention to this because I'm pretty sure that nurse was really busy. This is in the emergency department. She probably has 6 patients. And she's using some shorthand, but these are not really great ways of saying, I'm continuously asking the patient if he needs to urinate. He says he does not need to urinate or he does not need to pee. Okay, that's fine. But patient has to pee multiple times. That sounds like he's asking to urinate and we're not helping him do that. So that's not what that note meant. Okay. So prior to this admission, here's his old echo and 2-3. So it's like a week and a half greater. LV is moderately dilated and the wall of the left ventricle is thin. No thrombus. Of course, if the LV is dilated, blood stays in the LV. So you're always going to look for a thrombus and you always need to be aware. And his LV function is significantly reduced. We already know his EF is less than 15% and he has global hypokinesis. Okay. Right ventricle, secondary, assumably to the left ventricle, the right ventricle is moderately dilated. And you have a reduction in right ventricular systolic function. So what that means is the left ventricle doesn't actually eject effectively and the volume load in the atria increases and that it increases in the pulmonary vessel. And the same is true for the right ventricle. And we can see that there is mild mitral regurg and there is trace tricuspid regurg. And we're not surprised by that because as the ventricle dilates, it pulls the leaflets apart. So that's always really important. And now I want you to take a look at this kind of overview of our patient. Here he is. He's come in. He's in the ED. They get a venous blood gas before he transitions to our step down area. And here is his venous sample. So they don't have an A line. They're just doing a venous sample. I can't guarantee you that it's central venous. I hope so, because central venous samples are the ones you need to do. Peripheral venous doesn't tell you much. But if you're looking at this, there's something to be very concerned about. Okay. And I'm just going to tell you what it is. Normally, the oxygen in your vein, the dissolved oxygen, which exerts partial pressure, that dissolved oxygen in your vein should be around 40 to 50. Anytime it's less than 36, it means that your tissues are using a lot of the oxygen because you don't have good delivery. Now, that's no big surprise to us. We know he doesn't have good delivery because he has a reduced EF. Now, so venous oxygen should always be higher than 40. Anything less than 36 indicates to me that the patient has a profound problem. Now, you then would say, well, then I would have expected that the patient would have metabolic acidosis and that he'd have a base deficit and an acidotic pH. But this patient has been aggressively diuresed. When we aggressively diurese patients, we can mask their metabolic acidosis presence. So again, beyond the scope of the time we have here together, but this is an extraordinarily important aspect. My expectation with that PVO2 being that low is he should have been acidotic. He is not acidotic. He is alkalotic, and he is alkalotic because he's been diuresed. Now, what that also is going to tell us, and again, a little beyond here, is that our cells are going to take up potassium. So serum potassium goes down, and no matter how much potassium you're going to give that patient, you're not going to be able to resuscitate his potassium because he has metabolic alkalosis. He has metabolic alkalosis because he's been over-diuresed. Okay, so even though he's in heart failure, we're going to have to consider how is it that we're going to get some volume mobilized into his arterial bed. So I can tell you, for me right now, when looking at this, I would be advising or communicating that I would like for my patient to go on an inotrope. Okay, well, my doctor says, well, why do you want an inotrope? Well, first of all, his PVO2 is low, which indicates he has poor delivery. And now I'm going to come down here to his anion gap. His anion gap is telling me that he has acidosis. I don't see it here in his base deficit. I don't see it here in his pH, but I do see it here in his anion gap. So I'm going to be working to try to improve my patient's blood flow dynamic. So that, I think, really important. PVO2, and then, of course, looking at his serum sodium and his serum osm, which his serum sodium is extraordinarily low, but his serum osm is not that low. And I always want to be considering that what I really want to say about him is that he's hyponatremic and just barely euvolemic. He's almost hypervolemic. By looking at his osm, as the osm goes down, it means he has more volume. So I know I need to get rid of his volume somehow. He isn't making urine, and he has a profound alteration that tells me he has really poor blood flow. So I'm going to consider with this patient that I'm going to want to get him started on some inotrope. And then we just look at his chest x-ray. Well, my God, of course, look how big his heart is. You don't have to be a radiologist to actually see how much of the thoracic cage is actually obscured by the size of his heart. He has a huge heart. So all those things together actually put us into a position where we're going to talk about what to do. Okay, so cardiology on the phone says, put the patient on dobutamine, start low dose at around 2.5. We don't know how the patient's going to respond. Cardiology says, yep, he's got reduced EF, low output state, he has lactic acidosis, he has sinus tachycardia, and he got some fluid. But here's what happened, right? It makes sense. You think he needs fluid, but he's got heart failure. So when you give him fluid, he can't move that volume. So he got worse. He got really much worse when he got fluid, right? His SpO2 drops. He has worsening lactic acidosis. So first thing cardiology says, I love that. I love it when we agree. Get that dobutamine up. You're at 2.5. Go ahead and go up to 5. Okay. And once you've done that, maybe we'll see some renal flow. When we see some renal flow, we want him actually to waste some water and some salt. And that's why he gets Bumex. He's going to get Bumex after his dobutamine goes up. Don't give him Bumex before you go up on the dobutamine. You're trying to increase his renal blood flow. So let's give him Bumex after dobutamine goes up. We're going to give him some hydralazine because we want to promote some vasodilation, which will reduce the work of the myocardium without causing some other problems. And he says, okay, I'm going to look at this patient over the weekend. The patient's staying in the emergency department. Hopefully we're going to, the ED is a hard place to manage critical patients because even though we have excellent nurses in the ED and they're getting trained in critical care, they have more than 2 patients. They sometimes have 3 patients, 4 patients, 5 patients. This patient needs extraordinary vigilance and evaluation. All right, so now let's just kind of take a look at what happens with his heart rate. His heart rate goes up, and it stays up. Now that's going to be an ischemic burden. That means he's telling you that he's having some issues, and you have to correlate that with his laboratory analysis because you're not going to be able to see it otherwise. And his blood pressure stays relatively constant, but this is, of course, all oscillated blood pressure, which, okay, that's all you got. So that's what you have to use, okay? But very important to pay attention to that tachycardia and to the concern. First of all, we're on dobutamine, then we've increased dobutamine. Is that causing the tachycardia? Does he have an increase in myocardial contractility that makes the risk of tachycardia worth it? And how am I going to know that? Because I'm in the ECC. You better start making some urine, buddy. And I'm not asking you anymore about whether or not you need to pee. I'm going to give you a Foley catheter because I need to see response to your inotrope. When I give you volume, you should make urine. When I give you inotrope, you should make urine. If I give you an inotrope and your heart rate increases, but you're not making urine, we got a problem here. And that's something we want to be thinking about because we really do miss the diagnoses. Okay, now a different cardiologist comes, actually the cardiologist, not the resident, and he says, this patient has cardiogenic shock and he's beginning some diuresis. Today, he doesn't look to be in shock, but he was in class 4 cardiogenic shock, right? That should have moved him to the top of the pile to be admitted into the intensive care unit, okay? He has very severe, now on the new echocardiogram, he has severe diminished right ventricular function, which means that even when you give diuretics, he's probably not going to have good blood flow because his right ventricle has failed. By the way, for me, the number one thing at this moment in time is I want to do CRRT on this patient because I need to remove some of that volume and I need to remove it from his veins because his right ventricle is dilated and not very effective. And I'm also going to consider that he's on dobutamine. He might also need a right ventricular inotrope, and that will be more likely to be something like milrinone. And then he says, yeah, stop measuring that SCVO2 because you don't have a central line. You only have a PICC line. We don't know what that means, okay? Do not try to control his rate. Do not give him a beta blocker. Do not give him a calcium channel blocker. He's tachycardic, but this is compensatory for the fact that he can barely contract his heart. And the only way that he can maintain any kind of blood flow is with tachycardia. So do not control his rate. Okay. So he really needs some advanced heart failure therapy, which is like dobutamine or milrinone for 8 to 12 to 24 hours, etc. Okay. All right. So heart rate was high. Can't give him albuterol. Don't want to give him anything that's going to stimulate beta, right? We can't give him any beta block. He could have had parasympatholytic. He could have had albuterol and Atrovent. Atrovent will balance out a little bit of the beta stim that you might give when you gave a treatment. Okay. So I think, again, we're just ongoing. You can see tachycardia just gets worse and worse and worse and worse. And now you occasionally see a little drop in his SpO2, but he's looking pretty good in that way. And his blood pressure is very variable. That's because it's oscillated and it's not invasive blood pressure. But I do want to note this, right? So here you are, 28, 18, 27, 24, 16, 19, 32, and 24. Okay. Yeah, possible every hour you become more tachypnic and then you breathe normally. But this is very consistent with the worldwide reporting that we don't actually evaluate respiratory rate effectively. And you know that when you take the respiratory rate like 18 and you look at a blood gas and the patient's PCO2 is 25, you can't get a PCO2 of 25 breathing 18 times a minute. So really important, my friends, because you see all that variability. What that means is when your physician looks at that, they say, I don't believe any of it because it's too much variability and I don't think any of it is quite right. But I will mention here, patient's heart rate is now 149 and his respiratory rate is 32. We're missing something really significant here. Probably everybody's pretty happy. His blood pressure looks okay. His MAP looks okay. Oh, everything's okay with that patient. His oxygenation's okay, 96%. Oh my God, his heart rate is 149 and then progresses to 150. His respiratory rate is 32. What communication did we have about this? This patient is decompensating into heart failure. Okay, so ultimately it gets to the ICU, and now you see that this is kind of later. This is after the patient's gotten lots and lots of therapeutic intervention, gotten lots and lots of diuresis. So again, kind of looking at these blood gases, and we can see that consistently his PVO2, now it's coming from the PICC line, so I can't completely validate the value of it, but it is relatively central. I would have expected that to be higher. And it's very, very congruent with the fact that the patient has profound and significant heart disease and heart failure. What we're missing on him, what got missed on him was the fact that he seemed to feel okay, but that he was actually aggressively and profoundly deteriorating. So then we just look again at his chemistry. You can see now his sodium is dropping even more. His osm now has dropped, okay? His BUN has gone up. His creatinine went down a little, but it's about the same. He needs CRRT, and indeed, that is what happens. He does get cannulated for CRRT. Okay, again, EKG isn't going to tell us very much about this patient, not going to tell us about his heart failure, just tells us about whether or not he's having a STEMI, does he have ventricular hypertrophy, does he have bundle branch block, does he have an axis deviation, but doesn't tell us anything at all about his heart failure. So remember what he looked like. This was that first x-ray, and this is a later x-ray. It's very poorly penetrated, but you can see we haven't really progressed. We haven't really reduced his heart size. Really important for us to appreciate that. And then just to remember that cardiac shock progresses particularly with biventricular dysfunction, which this patient has, and it's exacerbated. They have a low cardiac output. They're hypoperfused. They may or may not have hypotension. He didn't have severe hypotension, but he had significant hypoperfusion. They get hypoxic, they're congested, they have organ dysfunction. They may have loss of vascular tone, vasoplasia, and a reduction in coronary flow. So that would be the end. That would be the end for what we're talking about today. First of all, we talked about the presence of Takotsubo, and to always question whether that's a possibility in the context of a setting where there's been something stressful, where it's women with hormonal balance, and particularly Caucasian women. It's also really, really important to remember that when patients are presenting to us in exacerbation of a chronic disease, so lots of times when we're in the ECC or the ER, we don't know what the patient's problem is, but this is a patient who presents with a reduced ejection fraction, less than 15%, and he's profoundly exacerbated. Now, he might look okay, but he is deteriorating, and he did actually deteriorate pretty significantly once he got into the intensive care unit. He ended up on dobutamine at 12, ended up with CRRT, had cardiogenic shock, ended up going to the cath lab. They thought about giving him an Impella. They didn't do that. They didn't think that he was a candidate for transplant, and they did not believe that they'd ever be able to wean the Impella. So they did medical management, and the best that they could in medical management. The CRT was really what saved his life. So I want to remind you, your role is to put that picture together, bring those symptoms and the lab values, pay attention when the patient is deteriorating, advocate assertively, always gather data and science. You just can't say, I think he looks bad. He's going down the tubes. He's going down the drain. He's circling the drain. He's got a soft blood pressure. You need to gather your data so that you can present that effectively and assist your physician in pursuing therapy. I'm very grateful that you joined today. For those of you on the line, if you wish, please stay on. I'm going to end the session for now. I'm going to end recording for now. And I'm going to say thank you for everything you do every day. And I hope to see you next week. Bye-bye.